Assalamu alaikum. Welcome everybody. Um, Today we will discuss apparently very simple thing, but this is what is called as bread and butter of anesthetist. So, like we should have very clear concept about what we can expect, and how we should prepare. So, what are different ways to induce a patient in general anesthesia? Yes, please.
So inhalational and intravenous.
Inhalational and intravenous.
Intravenous.
Where will you put awake fiber optic?
Awake fiber optic is maintenance of airway only. That is not
Okay.
induction of anesthesia.
Okay, so it will be a special circumstance in which you will be inducing the patient. Before that, you are taking the airway, and once you
Airway.
secure the airway, you will you will proceed further. Am I right?
Yes, sir.
Okay. So, okay, before we induce, like what preparations you can have, what preparations you can have to avoid any problems during induction. It's very simple. Actually, it's a first year resident question, but just try to just revise few things. Pre-medication, pre-medication for angiolisis. What else? Aspiration prophylaxis.
Also, there are many things like first of all, IV access, the environment of the temperature of our theater,
Very
equipment,
good.
important drugs, important or the relevant drugs and relevant airway, like relevant circuit. Like in peds, we need the Jackson Rees, and in the adults, we need the closed circuit, relevant masks, relevant laryngoscopes, and then we come to these pre-medication monitoring, our anesthesia equipment. It should be ready. Our gases.
Okay.
And stuff.
Okay, like you need some certain equipments, certain preparations like inhalational, sorry, for angiolisis, there will be certain option for angiolisis, there will be certain problems for aspiration prophylaxis. Okay, so IV line problems will can be there. Okay, so these will be the things which you will be preparing before you proceed. And what about airway? Airway preparation. Okay, so airway preparation is also one of the things which you should be like. In every patient you will have different challenges and different problems, but you should be considering airway. Then another thing is monitoring. This is very important part of inducing a patient. Okay, so in addition to this standard 1 and standard 2, like what will be in standard 2?
So standard one is presence of qualified attentive anesthetist,
Okay.
and standard two will include our SpO2, pulse oximetry, ECG, blood pressure,
Okay.
temperature.
Okay. So, what is special monitoring you can need in case of any like anything specific with relation to induction?
So intravenous, intra-arterial monitoring, arterial blood
Okay.
pressure monitoring.
Okay.
Uh,
What else?
Among else, we can have cardiac output monitoring. We can have
No, for before cardiac
central
out
venous
before. This is one very important thing which is important for induction. What is that one?
and tidal carbon dioxide.
That is part of standard 2.
That
Neuromuscular,
is standard two.
neuromuscular
Yes, sir.
stimulation.
Neuromuscular monitoring. Right.
Okay. And there is one more thing which can there here. is BIS monitoring.
Yes.
Okay, like I'm just
Yes.
dragging it, but nerve stimulation is important. Interarterial blood pressure monitoring you can do in certain specific conditions where you are expecting swings of blood pressure.
Something of
Okay,
blood pressure.
so
Large fluid shift.
sorry. Okay, so with reference to aspiration prophylaxis, either we give antacid like H2 receptor antagonist or PPI. Okay, this is one thing. Other thing is to give gastric motility agents like motilium, domperidone, or metoclopramide, or we give this one antacids like and a non-particular
Sodium
antacid.
citrate.
Sodium
Yes.
citrate.
Okay, non-particular antacid. There is one more thing which is controversial. What is that thing? NG. Okay.
Yes.
In certain cases, it will be needed, but actually it will create more problem than because it will only aspirate the uh, liquid part, but it cannot aspirate the solid particles. Just with reference to aspiration, what you can do, there is another thing which is not only for airway management, it is also helpful for aspiration prophylaxis, that is ramp position. Okay, ramp position will actually lead to decreased chances of aspiration because of the moving of
Gravity.
yes, against the gravity. So ramp position
Gravity.
actually
Yes.
will help you in protecting. Okay, so these
Yes.
are certain things. It needs some
So
time.
the most
Yes,
important is RSI.
very good. Rapid sequence induction or modified rapid sequence induction, especially with reference to airway pressures, should not exceed 15 to 20. Okay, 15 to 20. So this is actually part of your management. You should be thinking about these things, though it is interlinked with airway management. But if we just think about aspiration prophylaxis, we have to think about these things as well. Okay. So now some like there will be certain options for anxiolysis. For example, we can have midazolam in either any route. Okay. Or what else we can do for anxiolysis? Anything else? Or anything else which is part of pre-medication? It is glycopyrrolate or hyoscine, which can be a number of way. It will be protecting for post-operative nausea, vomiting as well. It will be decreasing the secretions with reference to hyoscine in specific conditions. So anything else? And actually, this one midazolam will also be related to actually midazolam or any other benzodiazepine uh, before night of
Reduces
surgery.
awareness.
I'm sorry.
It reduces awareness also during surgery.
Yes, very good. So another big problem which is there with reference to induction of anesthesia is awareness. So you have to not only because in certain conditions you are reducing the doses of anesthetic agents, and specifically another scenario will be that you are inducing a patient which is in shock. Okay, so this patient will be at risk of awareness. So if you are giving some small dose of midazolam, it will be helping you. Okay, uh, another, because actually I got this advice from one of our resident that you should use PowerPoint for these writing rather than words. So I liked his idea. Anyways, so another thing which you should be considering is multimodal analgesia, especially before induction will be, that is preemptive analgesia. Okay, so the advantage of preemptive analgesia will also be a smooth induction with preemptive analgesia. So what medications we can use for preemptive analgesia? Paracetamol, NSAID. Okay. Then another medication, who will tell? Gabapentin. Okay. What else? What else we can do? Which will help us in our actual induction. What about now? In addition to these things, the important thing will be this one, laryngoscopic stress response. Okay. So what will be the options to reduce it? Opioids,
Opioids,
then
Deep, deep planes of
be-
anesthesia.
beta blocker, deep, plain,
Yes,
short
sir.
laryngoscopy
Xylocaine,
time. Okay. And actually
lignocaine.
here also you can bring this RAM position, because RAM position will be related to short laryngoscopy. Okay.
Yes, sir.
Another thing will be another advantage will be that pre-oxygenation will be more effective and easy. Okay. Pre-oxygenation will, because FRC will increase, so everything will be going in the right direction. Lidocaine, either IV or spray. Which is better?
IV.
Why? Why IV is more important?
Sir, this topical or local anesthetic can also irritate airway.
Very good. So there will be chances of laryngospasm. This is one thing.
Yes.
Very good. What else? There is one more point. It will predispose for aspiration, because the protective reflexes will be gone because of this thing, because of topicalization. And another thing is actually, they are actually equally effective, even if you are giving IV or you are doing topicalization. Actually, both of them are equally effective. Okay. So another few words about pre-oxygenation, which is also very important with reference to induction of anesthesia. So what is the concept of pre-oxygenation?
To wash out all the nitrogen from the FRC. So the FRC contains a lot more oxygen.
Okay. Like you are doing denitrogenation. So instead of instead of 21% oxygen, you are giving 100% oxygen for about how to do it? 4 to 5,
100% oxygen,
So
3 to 5 minutes.
a
3 to
proper
5.
fitting mask,
Yes.
the APL valve fully open,
Okay.
a flow for a fresh gas flow of 10 liters, and so 3 to 4 vital capacities,
Okay. Just
or 3 minutes
my
under
question is that what will be the role of APL and what will be the role of 10 liters? What is relation of this thing with pre-oxygenation?
So all the flow that's going, because we are increasing the flow.
Hmm.
So um, so with each liter, we are increasing more and more percent of oxygen into the air,
Okay.
into the whatever the patient is
Any
breathing.
any
No,
comments,
but
Zishan? Is it mandatory to have
sir, nahi.
APL valve open and 10 liter of flow?
APL valve, when the patient is spontaneously breathing, it should be open so that not much PEEP is generated.
CPAP,
But 10
CPAP,
liters is still too much. Yes, sir.
CPAP.
CPAP is
Okay,
not
CPAP.
generated. But 10 liters is still too much, because 10
Ex-
liter can cause barotrauma.
How
Okay,
can it cause barotrauma with spontaneous ventilation?
no, no, I will say that your point is correct, but actually we don't need that much flow. Okay. When we are
Okay.
coming out of anesthesia, we increase the flow for the gases to wash out from the circuit, and it is only transient. Okay. So actually, theoretically, you need vital capacity breath to replace rather than flow. Okay. Because even if you make 15 liters of flow, the oxygen which will be going will be according to the FRC. Am I right? Do can flow affect FRC? No. Okay. If the patient does not have good FRC, if the patient does not have good respiratory effort, can this flow compensate for the effort of the patient?
No.
You got my point? So actually, when the APL valve is open, there will be not chances of barotrauma. But thing is that actually it is useless. Okay. So theoretically, you are giving 100% mask with tight fitting mask, because if it is not tight fitting mask, what will happen? There will be entrainment of air.
Air entrainment, yes.
There will be entrainment of air. So the 100% oxygen will not go. So tight fitting mask is important. Vital capacity breaths is important, or normal breathing for 3 to 5 minutes is important. And how will you come to know that you have given the pre-oxygenation? By end-tidal O2, or what
More
else?
than 90%.
Huh? End-tidal O2 more than 95% or 90%, I'm not sure exactly. End-tidal O2 you will be monitoring with the agent analyzer, and what else? Anything else?
And tidal nitrogen.
End-tidal nitrogen. Okay, very good. What else? We will never do it, but ABGs, or if the saturation was before less and now it has become 100%, this will be a vague idea of what you are getting. Okay.
So how
So
much flow?
flow, you see, remember one thing. How much flow is required for that circuit? Flow has nothing to do with pre-oxygenation. Remember this thing. You should have a flow adequate to avoid rebreathing. Rebreathing does not necessarily need 10 liters of flow. You understand my point?
Yes. So for a Mapleson D, for
Uh,
coaxial Mapleson D, how much
uh,
flow should we keep?
actually, thing is that now um, uh, uh, these circuits, Mapleson type circuit is a
So that
history
is
now. Still, maybe in some exams they are asking, but nowhere in the world actually they are being used now. When you have
Okay.
modern anesthesia workstation with closed circuit, I don't think so it is needed. Okay. So I think it
generally
should,
flow equal to minute ventilation is enough.
minute ventilation will be enough according to the circuit. Maybe in certain circuits it will be needed 2 to 3 times, but especially it will be in controlled ventilation, not spontaneous. Just have a look, because I have very weak topic this one. So anyone can correct me that for spontaneous ventilation, how much in which circuit needs more flow?
Um, Sir, for spontaneous ventilation, equal to minute ventilation, we give for Mapleson A. That
Mapleson A.
is Megan.
That is why that is the most perfect circuit for spontaneous breathing. Okay. And for
Yes,
Bain circuit, it is good for
2 to 3 times.
flow. Bain circuit is important for mechanical ventilation,
Controlled ventilation.
control
The positive.
ventilation, positive pressure ventilation. Okay. So because I never studied it for many years, so and even when I used to study, I always used to forget about it. So I'm sorry for it. But usually that much flow is not needed. Okay. So we
Sir,
just okay. Yes.
mostly we give 5 to 6 liter to prevent rebreathing
In
in spontaneous breathing patient.
which circuit?
Uh, with the circle system, or when we are using any face mask like this.
Okay. I apologize because this concept is washed out of my mind at the moment with relation to flow.
Okay, sir.
Okay. So I need to review this thing. Zishan, if you can Google it and tell during our discussion, I
So
will be obliged.
it's written good in Brine Hall.
Okay,
I can
I will
share it
move
later
from
on.
here. I will just try to, if anyone can help me out in this thing. But we have discussed about angiolisis. We have discussed about aspiration prophylaxis. Okay, we have discussed about monitoring. We have discussed about different options of yes. Oh, now we will come to different concepts
Analgesia.
related to inhalational and IV induction. Okay, because this is what is my interest, and I'm doing it myself perfectly. But of course, there is not much data available for this. Have you heard of cocktail induction?
Yes,
Anyone?
sir.
So
Cocktail like propofol and ketamine, or you
you
mean
can make?
IV and inhalation?
Yes, you can have anything. Okay, so like basic concept you should be knowing that your ideal induction should be hemodynamically stable. Okay, and it will be evident with heart rate and blood pressure. So this is one thing. So when you are doing the laryngoscopy, the muscle relaxation should be there. You should have easy laryngoscopy. Okay, then there not should be too much secretions. What else? Awareness. There should be no awareness. So, and of course, if you are giving preemptive analgesia, actually, what will happen? The MAC will be reduced, decreased MAC requirement. And if, for example, if you are combining inhalational with IV, what will be the advantage actually? Will there be any advantage?
Sir, inhalational takes more time. If we are giving IV induction matlab, induction will be achieved within seconds.
Mhm.
So, what will be advantage of combining
Yes,
inhalational with
I
IV?
will give you a concept if you understand or if you appreciate. Thing is that when you are giving IV induction agents, do you know how much time propofol effect will be there?
2 to 3 minutes.
minutes.
Effect is 3 to 5 minutes, I think.
Okay, for example, we consider 3 to 5 minutes. Okay, then
Yes, sir.
sometimes there is a lag time, like you connect the circuit, you fix the tube, and now you open sevoflurane, for example. Okay, so in how much time you are opening at 2%? For example, I'm just giving you example. In how much time this sevoflurane will take its effect?
Yes, sir. But after we have given propofol, when the patient is sedated, we
Hmm.
start our inhalational agent even
Okay,
before
okay, that
intubation.
before intubation. Yes, in cases of, that's why actually, that's what I'm telling you, that there are some people who don't open, okay, who
Right.
don't open sevoflurane inhalational agent, because actually, like, they think that it is not needed, patient is sleeping. Okay, so
Mm.
but there is again, because this 3 to 5 minutes is relative. Okay,
Yes.
sometimes propofol effect can be prolonged, and sometime if it can be even less. Okay, so
Yes.
that's why this in between condition occurs. So if you want to avoid this thing, if you are giving side by side inhalational agents, because if you are opening it together, so you are actually, there is a concept that you should be targeting the MAC. Okay, you have to achieve the MAC, because this is a big confusion which is there in many of the people. Majority of the people, even I, unfortunately, I have seen this, many seniors don't have this clear concept. Even I think maybe I learned it when I started using agent analyzer. Okay, when you started using, because you cannot understand MAC concept of MAC till the time you are not using agent analyzer. Okay, because if I ask this question, what is 1 mAh of sevoflurane? It is 2%. Okay, so for example, if you have opened the dial at 2%, are you sure that you are giving 1 mAh?
No, we
No,
cannot be sure.
Very
because
good.
only
Okay, so
50% of patients.
yes, because other factors will be very important, will be minute ventilation, will be flow, how much flow you are giving, okay, and the requirement of the patient. So there are so many things. So if you have opened the sevoflurane dial at 2%, there is no guarantee that you are actually achieving 1 mAh. Or if, for example, if you have make it 4%, even then you are getting, but you are not sure. So there is only one option you are sure is with the agent analyzer. If you don't have agent analyzer, you cannot understand. Okay, so when you have agent analyzer, actually it's very easy. Then you can maintain with the flow. If you are giving a high minute ventilation, high flow, and high dial concentration, what will happen? You will achieve the MAC very quickly. Okay, and once you achieve the MAC, then you can adjust all these things. That because, like I will tell you, that if you want to have very quick induction, you will make it 8%. Okay, but unfortunately people are afraid that if you have opened the dial at 8%, there will be so many questions. What are you doing? Okay, so have anyone of you who's using sevoflurane make it 8% in reduction
Yes, sir.
Yes, sir, in children.
in
Yes,
children?
indeed.
Okay, so is there any harm in giving it in adults?
No, sir.
Okay, so the concept is that if you are using the agent analyzer, your target is you should not look at the dial. You should be looking at the MAC. If it is 1 MAC or 1.2 MAC or 1.5 MAC, you will look at, if you have the agent analyzer, it will be showing you. And for laryngoscopy, you need 2 to 3 MAC. Okay. For laryngoscopy, you need 2 to 3 MAC, which is called as MAC bar. Blunt adrenergic response. So initially, if you want to be sure that your laryngoscopy should not have anything, there are so many options which you can apply. So this is, I hope you understand. I hope I have given you this concept of MAC, because people just open the dial at the number and think that we are giving 1 MAC. Okay. So similarly, if you want to achieve it quickly, you have to do all these things: increase minute ventilation, increase flow up to, maybe now you can, if you make this flow at around 10 to 12 liters, you will achieve it quickly. Okay, because the circuit will be primed earlier. Then you will have the dial concentration, and once you achieve the MAC value on agent analyzer, if you don't have agent analyzer, even then, if you can just imagine, and then you can do, and then the results will tell you that heart rate will start coming and blood pressure will start coming, and you can do it even without agent analyzer, but it is not safe. Okay, but as a concept, if you understand this thing, that if you open the dial on 2% and think that you have achieved the MAC, it is wrong. Okay, so this is very important. And another thing is that when you are doing pre-oxygenation, for example, if you don't expect difficult intubation, if you just open nitrous oxide and sevoflurane and have the few breaths, so there will be effect of concentration effect and second gas effect, and your induction will be fast, even faster. Okay, so you can use this concept as well. But because of at time of induction, people are afraid of giving nitrous oxide, that in case they are not able to intubate, there will be problem. So of course you have to outweigh risk versus benefit. But if you want to increase the everything fast, make fast everything, you can do it. Okay, so there are certain things with reference to muscle relaxant. Okay, actually with the availability, whenever you have rocuronium and sugammadex, actually since last almost maybe 11 years, maybe I have I have never used, I don't remember when I used saxamethonium. Okay. So saxamethonium, even maybe I was just thinking one day, I think I have forgotten the dose as well because I've never used it. So whenever you have rocuronium and sugammadex, actually you don't need saxamethonium. Okay. But of course, you have to in exam and practically if you are in a setup you don't have, of course you have to use it. But there are certain things which you can you can certain techniques which you can use to smooth look to make your induction more smooth. So one of them is the concept of pre-curization. Okay, this is one thing, and one thing is priming. So anyone knows about it? What is pre-curization and what is priming? Anyone, please?
The pre-curization is when we give
Mhm.
less than half the dose of atracurium or the non-depolarizing muscle relaxant before
Mhm.
giving saxamethonium.
So what is the concept about it? What is the advantage of it?
Sir, post operative myalgias will
Myalgias.
be reduced.
And what about
And
IOP,
fasciculations will
fasciculations?
also reduce.
Fasciculations are
ICP,
related
IOP,
to what about IOP and ICP?
they will remain stable, I think.
I think there will be some effect on IOP, the IOP effect, but ICP, don't think so because ICP is independent of that thing. I'm not sure about it, but just check it about it. Okay. But if you are doing doing this technique, that the dose of saxamethonium will be increased. Why?
Because acetylcholine receptors are already occupied
Already occupied. Okay.
by
So the
non-depolarized.
concept, because the this saxamethonium is depolarizing muscle relaxant. Okay. So depolarizing muscle relaxant needs acetylcholine receptors. So if there is no acetylcholine receptors there, because some of them will be blocked already by the initial dose of atracurium or rocuronium, for example. So you will be subsequently needed increased dose. That is the same concept which is there in myasthenia gravis. Okay, because in myasthenia gravis also there are less receptors. So there is resistance to saxamethonium. Okay, and if you are giving high dose, there are chances of dual block. So this you think we should be knowing. The other thing is priming. And the priming concept is the same, but usually you give around 1/10 or 1/5 of the dose before giving induction agent. Okay. So actually, what will be the advantage that once you do pre-oxygenation and you have given, because actually, if you are giving a cocktail, that now I come back to the what I was telling you, cocktail, because the same concept which we are using in precurization, here it will be that some of the receptors will already be blocked. So when you give the rest of the dose, the intubating conditions will be achieved earlier. Okay. Another with or without priming will be increased dose. For example, if you are giving 1.2 milligram per kg of rocuronium, you can achieve the intubating condition within 60 to 90 seconds actually. So practically it becomes just like saxamethonium, because usually if I know that there is a long procedure, you should give high dose. There is no problem, because for example, if patient will be, you will not be able to intubate, you still will need sugammadex. Even if you have given 0.6 milligram per kg, even then you will need sugammadex. So if you have the availability of sugammadex, and of course you will not do these magics in patients in which you are expecting difficult intubation. Okay. So the concept of priming and precurization should be very clear. You are giving a small dose of the muscle relaxant before giving induction agent. But now what will be the things that if you are giving rocuronium, it's a painful injection. Okay. So it is better if you give some lidocaine first, and then maybe, because I will come back to what I was telling you about cocktail. Actually, the advantage of cocktail cocktail, actually you can make any combination. Okay. But if, for example, if you are using ketamine in a very, very small dose, around 0.25 milligram per kg, for example, usually it is around 20 to 25 milligram in adults. It has so many advantages without any practically no disadvantage. If you are using ketamine in a very small dose, nothing happen. A patient is absolutely perfect. So if you are giving ketamine and lidocaine, and then you give a small dose, of course, you will be doing the pre-oxygenation. And of course, everything will be ready. All the air equipment will be ready. And you have made the patient RAM position, and then you've made the pre-oxygenation. Then you give it, and then you give the rest of the dose of this one, rocuronium or atracurium, whatever you are using. So the advantage will be that the intubating conditions will be achieved very quickly. Practically speaking, you make the time duration half. So you quicken the induction. Okay. So that is the concept. Another medication which you will have, which you'll be needing, is opioids. Okay. So there are a number of people who are using opioids, for example, with the patient who have fentanyl available, if you are working in a setup where you have fentanyl and morphine. I have seen people don't give morphine before induction because they think that they have to give it at the end of the procedure for post of pain. I don't understand this thing, but because practically I don't have the data to support myself. I have not searched in it, but actually this is what I am doing very successfully, because I give morphine before induction. So what is happening actually, you will not I'm using very, 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 very small dose of propofol. Maybe these days I'm just trying to reduce it. Even I'm not giving more than 50 milligram in any patient. I have induced even 150 milligram kg patient with this technique in a very, very simple way. But I give morphine and fentanyl even because fentanyl, people think that fentanyl is a wonderful medication, but actually I in my current experience, again I'm telling you, you cannot quote these words. I'm telling you my personal experience only. Of course, people use fentanyl to very good effect, but I have replaced fentanyl with dexmedetomidine. Because what I do, that I just start a dose, you can say 0.2 microgram per kg per hour, 0.1 to 0.2 milligram per kg, or even under certain circumstances, maybe increase the dose of dexmedetomidine. I start with the infusion. So what happens, the role of fentanyl becomes very, very, it is not needed much. Okay. But whenever be very careful with Presidex, this dexmedetomidine, because whenever you are using dexmedetomidine, people give it in bolus. I will never recommend you to give bolus, because bolus can cause sudden bradycardia, which will sometimes be difficult to handle. But in my experience, if you are using it in infusion, nothing happens, because as soon as you see the heart rate going down, actually you stop the infusion or you reduce the infusion. Okay. So with this technique, I am using this technique with very good effect. Practically speaking, what I am doing, I'm using only 10 to 20 mics. I put it in the drip. So actually it is non-technical. Ideally, you should not be giving it without infusion pump. But practically, it becomes sometimes difficult to arrange syringe pump in every situation, in everywhere. But if you are using only 10 to 20 mics in a dedicated line, you can increase or decrease the rate of the fluid very easily, and you are getting the result. So what I do, that I give a very small dose of, I'm only giving 25 mics of fentanyl and 5 to 10 milligram of morphine according to the surgery being performed, because morphine effect will remain for more time. Okay. So if you have a long surgery and you know that you need to have a good analgesia, if you are using fentanyl, maybe after, even if you have given, people use 100 mics of fentanyl, 200 mics of fentanyl, 300 mics of fentanyl, and the time they are giving the NCN again, the patient becomes tachycardic. So actually fentanyl, because fentanyl is highly lipid soluble. So what happens? Fentanyl, you give it, and fentanyl does not remain in the circulation for a long time. And it's not because it's highly lipid soluble. You can read about it, that how much fentanyl, how much is the circulation time for fentanyl. because in my experience, fentanyl vanish from the circulation very quickly. So why to waste it? Because I have achieved this effect with in this technique in a different way, and a very good effect, because now dexmedetomidine is my grandfather, because dexmedetomidine is controlling the heart rate like anything. But whenever you are giving dexmedetomidine, make sure that you have glycopyrrolate or atropine with you, ideally glycopyrrolate, because definitely heart rate will come down. And actually the whole purpose of your anesthesia technique or anesthesia induction is that you don't let the heart rate and blood pressure goes wild. Okay, especially you don't want tachycardia. So if you use dexmedetomidine with the purpose, with care and caution, believe me, it is giving such a wonderful effect. Because opioids, especially if, for example, if you want a long effect, you should use morphine. Or in our setup, for example, you people are always having only nalbuphine, so you can use the same amount of nalbuphine before induction. You give 10 milligram, or if you have a long surgery, give 20 milligram of nalbuphine. You know that the surgery will last for 4 to 5 hours, for example. You don't worry. You give it, and now after that, your induction agent, and don't give propofol fast. You have to give propofol slowly, 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 and slowly. Okay. And especially you should be giving a higher dose of muscle relaxant. I guarantee you that your intubating conditions will be achieved very quick and very effective. Okay. But of course, there will be certain exceptions in which you have to be more careful. And in that circumstances, especially what I'm telling you, that if you are not giving adequate amount of midazolam, and you have not given, so maybe if you are giving less dose of propofol, and of course, if you are not using inhalational agent, maybe you can have awareness. But because I'm using multiple medications together, morphine for slightly, morphine effect will come slightly late, and the time when you are giving the Insian, even at that time, there will be analgesia. Fentanyl you are using, it will be getting some effect quickly, and you are augmenting it with a small dose of ketamine, and you have given paracetamol and NSAID also as preemptive analgesia before you are doing anything. So my suggestion is that when the patient comes, you attach the monitor and try to give paracetamol and NSAID before. You can have antibiotic at the same time. You can start this infusion of dexmedetomidine, and then you start your induction. You can give some lidocaine, you can give some ketamine, and then you give muscle relaxant, and then you give propofol with this muscle relaxant with the priming technique, and I'm using it successfully. Of course, this is not bookish. This is only my practical experience which I'm sharing to you. Of course, there will be some ifs and buts, but if you are in a controlled environment, try in some patients. Okay, try in some patients, and you will, and even you can come back to me with some results. Okay. So some chat box, sir, you are sharing this meeting on YouTube daily, please. MashaAllah. Mr. Hafiz Shoaib. Unfortunately, people don't follow. Everything is there. Whatever I am doing it, not every time daily, but whatever is there on YouTube. Okay. So of course, because my aim is to give you a vision to anesthesia out of uh, so-called textbooks, especially your love, your the one you all of you worship, Morgan. Okay, so my aim is to liberate you people from that terrible book. So because I have some other interest as well, I'm reading and teaching some Arabic grammar as well, so you will find it. So apologies for that. Because I'm not a very good technical person, so whatever I'm doing it, I have this channel, I'm putting it here. So you will find it all the playlists here. Okay, and you can find on any topic you want over here. Okay, so I have all the discussions on these basic topics. Actually, unfortunately, I am unable to do much of them. My aim was to do some basic sciences topic, pulse oximeter and tidal CO2, blood pressure monitoring. Okay, so I hope you find this like of some value. Okay, and you all are welcome for any question anytime, because this topic you will not find in any book. This is like, if I summarize you, you always chalk out a plan. Your airway management should be there. You consent, you prepare everything, and then you can consider certain things in your mind, that patient can have awareness, patient can have aspiration, patient can have anxiety, the blood pressure can go crazy. You might need to have monitoring with reference to awareness, with reference to neuromuscular stimulation. I have just shared with you a weird sort of anesthesia induction technique. Try it. Okay, never believe anyone. You can try it in a programmed way, one by one. But my basic concept is that you should be knowing the pharmacology of the medication. Like when I come to know, or what I practically use fentanyl, I think fentanyl is useless unless you are giving it in infusion. If you are giving a certain dose of fentanyl as a baseline, and after that it will finish very quickly. So if you are not using any other medication, you have to give either repeated boluses of fentanyl, or you have to give it in infusion. But because I have the same purpose which I got from dexmedetomidine, I tried it with the lidocaine infusion. Lidocaine infusion is also amazing. I have not tried magnesium sulfate infusion, but people use it also for maintenance of anesthesia. It will reduce the MAG and everything. So we discuss about the certain concepts about inhalation reduction, certain things which you need to know about IV induction, monitoring. That's it. Yes, Tayyab.
Sir, my question is regarding ketamine use before induction. This low dose is actually analgesic dose.
Very good. It is analgesic
But
dose.
should we? It would not be better if we use it after induction.
What will be the decide? You can repeat. If you want another dose, you can give another dose of 20 milligram of ketamine. That time, actually, what will be happening? People think that ketamine will cause tachycardia. I can guarantee you that if there is a pain and you give a small dose, only 10 to 20 milligram of ketamine, I can bet on it, the heart rate will come down. If the heart rate increases because of pain, okay. So I use it because remember one thing, propofol, people think as if they are giving, like, one day I went to a new hospital where I am working now. I saw people giving me 400 milligram of propofol for lap sleeve gastrectomy, and I started smiling at him, and I showed it to him. Give one 200 milligram syringe to anyone else, and I will only use 50 milligram. And that day, believe me, I use 50, 50, 50, 50, four lap sleeve in with one propofol injection. Okay. So he was just looking at me like I'm doing something out of the world, but I showed it to him. So that's my suggestion to you. Try to do different things. You should have the concept. Okay, I'm using ketamine. This will be the effect. I'm using propofol. This will be the effect. I'm using midazolam. This will be the effect. If you give 5 milligram of midazolam, 10 milligram of morphine, and you give dexmedetomidine, and you give sevoflurane, and now after the surgery, you are sitting with the patient for 2 hours. Of course, patient will not wake up.
Okay.
Okay. So you
Sir,
are using.
and
Yes. Yes.
another question is, with this low dose, should we use for
Glycopyrrolate,
secretions
nothing
glycopyrrolate
happens.
or not?
Actually, because I tell you something, everything is relative. Because I'm using dexmedetomidine, in every other patient, actually, heart rate goes down. So glycopyrrolate, actually, I have also, whenever I have low threshold, if the heart rate comes down, I stop dexmedetomidine and or to reduce the dose, and I give glycopyrrolate. So you can give glycopyrrolate. Another advantage of glycopyrrolate is that I have now, again, I will tell you something, that these are only, please don't quote me anywhere out, because people will say that I'm distracting you people. But try to people put airway. Yes, I forgot this thing to tell you. People put airway very early, very early. Even there is a concept of putting airway throughout the surgery. I don't understand why they are doing it. Airway is an irritant. Okay, even at the time of induction, airway should be the last thing. Of course, you read in the books, you prepare, okay, put it. Airway is actually your failure. If you are putting airway very early, it means you don't have the correct technique to hold the mask. if you hold all the did all the maneuvers, and then at the end you put airway, okay, fine. And of course, I'm not saying that you should not use airway, but airway should be the last thing. If you are starting with airway, it means your technique needs to be attended. You should put it. And another thing, at the end of the surgery or throughout the surgery, they put it because they think that they are preventing tongue bite. Preventing ETT bite. So actually, again, I will tell you, for that, you can just put something between the teeth. Even the airway, if you are putting it for that purpose, it should be put only between the teeth. Why you are putting airway all the way through to Saudi Arabia? Well, you don't need it. You just put it in between the tooth. If you want to prevent ETT bite, think about it. I'm just giving you an idea. Try not to follow others like we are not thinking using our brain, and we are just following others. Oh, other person is putting airway, so I also have to put airway. The purpose of airway, you should know. You are only trying to prevent the tongue bite. Sorry, I'm again using this tongue bite. I only prevent ETT bite. So you can only put something in between the teeth, and that will serve the purpose. This is one thing. And another thing is that I'm with use of glycopyrrolate, sometimes secretions become dry. And actually, I am trying not to use too much suction at the time of recovery. And actually, sometimes I'm just trying to reduce if I look at it and there is no suction, because ideally suction should be done under vision. Before the patient is light, you should put a laryngoscope and do the suction under vision. Okay, so that should be the standard of care, but unfortunately we don't do it. Okay, so thanks a lot all of you for attending the discussion, and inshallah we will come back with some another topic. Thank you.
Thank you.